Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
All right, what's up, y'all? This is Erin Faules, one of the Wild Health docs, coming back to chat with one of the other new Wild Health doctors, Dr. Damon Forbes. Damon is awesome. We're super glad to have him on the team. He's a critical care doc in Asheville, North Carolina. So now two of our docs are in that area, which is cool. I'm a little jealous. It's really pretty in Asheville. But he's a wealth of knowledge. We're excited to have him here. And today he and I are going to dive into lipoprotein A, or Lp(a), what it is, what it means, who should get tested for it, what you can do about all that stuff. So we're going to do a little bit of a deep dive there. And you guys may have heard Damon recently. He did a podcast with Dr. Jeff Graham on the mass hyperresponders and kind of dug deep into the literature there, which is a super fascinating topic. I'm sure perked a lot of ears in our audience. But Damon, tell us, in case people missed that episode, tell us just a little bit about yourself, since you're one of our newer docs. People may not be as familiar.
Yeah, so I appreciate the introduction. I'm still practicing pulmonary critical care medicine full time, a little bit of sleep in there as well. I do plan to eventually exit that over the next few months and to join Wild Health on a more full-time basis. I have lots of interest related to wellness, but certainly the cholesterol ongoing research debates, where low carb diets fit in is kind of a personal passion of mine. So I think that's how I ended up with the talking about the lean mass hyperresponders.
Nice, Brad. Cool. And you were in the military. You're a dad. What else? Any other
Yep.
high points?
Spent 11 years on active duty, still serving in the
Yeah.
Army Reserve.
Right.
That's winding down as well.
Cool.
I've got 3 kids, 18, 16, and 11. One of them's in travel soccer now. So yeah, life is busy for sure.
So busy.
Yeah.
Yeah, man, you're crushing it on
Yep.
on all fronts. I love it. I love to hear it. Well, we're glad to have you here. So let's talk about Lp(a). So this is something that I think a lot of our patients are familiar with because we check it in our panels when people come on board. But is this something, in the population you work with otherwise that would you say people are generally familiar with, practitioners and patients alike? Is this something like checked a lot, talked about a lot? I'm personally curious, and we're going to dive all into it, guys, of why this is important and why we check it on everybody. But I'm just kind of curious because you have a different perspective. I haven't been practicing in the other realm of healthcare for about 5 years now.
Yeah. So surprisingly, Lp(a) still hasn't really gained a lot of traction. I would say generally, broadly speaking, in primary care practices, it's in the guidelines, right? The cardiology guidelines certainly recommend that we check it at least once. But despite that, it doesn't seem to have crossed over. I'm seeing lots of folks at Wild Health who have never had that lab checked and are really curious about what it means. So I think it's becoming a very popular research topic. It's certainly the guidelines across the globe now address Lp(a). So I hope that this will eventually translate into sort of the broader general primary care practices. But so far it doesn't seem to have done so, at least not in my experience.
Nice. So hopefully I don't butcher this because I've never been the best at explaining cholesterol.
Uh-huh.
But people are generally familiar with the general lipid panel, right? You've got your total cholesterol, your HDL cholesterol, your LDL cholesterol. The ratio of the LDL and HDL used to be the bee's knees and in what was looked at, and the total cholesterol, that and HDL were kind of what people really looked at in terms of what needed treatment. We kind of know that that's a little bit thrown out the window now, right? So we really, really care the most at Wild Health about your apoB and your Lp(a). So both of those are proteins. Well, the apoB is a protein that can get attached to your LDL cholesterol, or what people know as bad cholesterol. I really like that terminology, but people are familiar with it. Um, Lp(a) is when there's another protein, apoA or apolipoprotein A, that's also attached to LDL. This really changes the behavior of the LDL protein, basically. It's pro-inflammatory, and really can be problematic in terms of cardiovascular events. And one thing Damon was kind of alluding to is how common this is in the population. So something like 1 in 5 people, or 20%, upwards of 20% of the population, can have an elevated lipoprotein A, or LP little a. So this is capital L P parentheses lowercase a, if you see this written down. And this is really important because one of the big reasons it's important is that it's genetically driven. So you can determine from a really young age if there's an increased cardiovascular risk, and it's really highly correlated with increased cardiovascular events, heart attacks, strokes, or ischemic strokes, etc. So tear that apart, Damon. Fill
Yeah,
in all
no,
the
that's great.
gaps.
It's probably yeah, no, that's I think an excellent overview. It's probably then this is a good time to talk about like what LPA is, right, in relation
Yeah.
to LDL. So they're very similar actually structurally. The LDL particle has an apoB attached to it, as you mentioned, and so does LPA. The difference with LPA is that it has an apolipoprotein A, little a, attached to the apoB as like a
Like
long
another
tail.
protein attached.
Exactly, and so if we call it a tail because it sort of looks like a tail structurally, and that tail can vary in size and length, and that is genetically determined. Right, 90% of LPA elevation is really a genetic phenomenon. The other 10% we'll talk about later tends to be things like inflammation that drive that up. But yes, very similar structurally, but it's got that extra tail, and that extra tail drives a lot of the fundamental problems with LPA as a molecule. That tail allows, basically interrupts clotting, breakdown, and so it's a sort of a pro-clotting piece of the LPA molecule, and then LPA also carries a lot of oxidized phospholipids, which we believe to be atherogenic. So it's got both a risk of increasing or aggravating clotting, but then also potentially of driving progression of cardiovascular disease.
Yeah. So this is kind of tricky because sometimes we see like I don't know if it's a true increase or relative increase. I think a bit of both, actually. When someone starts on statins, you can see LP little a drive up a little bit. Um, and you also can see a little bit less of a decrease in the LDL drop. I don't want to get it twisted. For people with with plaques present, with cardiovascular disease present, or at high risk of plaques forming with an elevated LP little a, the reduction that happens in your apoB with statins is still very beneficial. So even if you see a modest increase in in the LP little a, it's still beneficial to start a statin. So I don't want to like get that twisted for anyone listening, but it just, the way these structures work and the way they sit on the receptors of the cholesterol molecules, it can just affect the way these meds work too, right?
Yeah, that's exactly right. So the common lipid-lowering drugs that we use, statins obviously being one of them, PCSK9 inhibitors being another, have sort of can either decrease. In the case of PCSK9 inhibitors, there is generally a reduction in LPA, although it's not indicated for that, isn't considered to be an LPA lowering therapy. The
Like 20%, right?
Right, a roughly 20 up to upwards potentially of 30% in some cases. So we know that that's an effect, but they're still not indicated for that purpose. Statins have a more variable effect. In some cases, they can actually increase LPA, and that happens because statins actually stimulate LPA gene and then the production
Oh, I
basically.
didn't realize that.
Yeah, so it's at the gene level.
Interesting. So it's definitely
Um,
not just a relative increase because of
no,
the
and that
blocker
yeah,
net. Yeah,
yep,
it's
yep.
a true increase. Interesting.
Right, but if, as you said, if you were on a statin for some other indication, that would still be the focus of the treatment, right? I mean, we know that LPA may rise a little bit, but that in and of itself isn't considered to be a problem for statin therapy per se.
Yeah, and for people with a really high LP little a, if you're not seeing as big, sometimes you don't see as big of a drop in your
Yep,
LDL because of the way these things interact with the receptors, which is what the
right.
statins work on.
Yep.
So you may need another agent. So
Mhm.
commonly, I think people with a really high LP little a, especially once they're at much higher risk of cardiovascular disease after, maybe 45 or so, adding something like a Repatha to your, protocol is probably a really good idea. Now, obviously, this is all generalized talk with, your case is going to be specific, but you may see a little bit more of a plateau in your LDL lowering, but you'll probably see a more true, like your apoB is going to lower more effectively still with a statin,
Yep.
even if you have an elevated LP little a. So super interesting. So who should be tested for this, Damon?
Yeah. So based on the current guidelines in North America, so both the U.S. and Canada, Europe, India, China, most of the global cardiology guidelines recommend that everybody gets tested at least once in their lifetime, because this is predominantly genetically determined, right? As I said, about 90% of this is going to be genetic. This isn't necessarily recommended to trend over time with therapy, at least not yet, right? And we'll talk about some treatments on the horizon potentially for LPA, but for now, everyone should get it at least once, because it does frame overall cardiovascular disease risk. There are kind of really the two numbers on an extended lipid profile that seem to be both predictive and potentially causative are apoB, as you mentioned, and LPA. One of them we have targets treatments for. LPA, up until this point, still to this day, we don't really have a lot of specific therapies, although there are several coming down the pipeline.
Yeah. So if you're in a group that's getting this tested, or if you want to get it tested, it's honestly not that expensive of a lab to get.
Right.
Um, what do you do if there's no treatments? Like, how do you approach these patients
Yeah.
that have that elevated lipoprotein A? Because the last thing we want to do is give people like disempowering information, right? That, this is just deterministic. You're going to have, heart disease if you have this thing. Like, that's not the way it works. I personally look at LP(a) very similarly to how I look at an apoE status in an individual, but
Exactly.
I'm curious how you approach it.
That's exactly right. I think that's a perfect analogy, right? We know that apoE4 increases the risk of dementia for sure, right? Quite substantially. And so whether you have one copy or two copies, that doesn't mean you're certainly going to develop cognitive impairment or dementia in your lifetime. What it means to me is that we have a window of opportunity to really optimize all the other inputs that drive that pathophysiology. Same thing with LPA. So for now, if you have a substantially elevated LPA, or LP(a), then really it just means that we have to focus on managing all the other potential risk factors related to cardiovascular disease progression, right? With systemic inflammation, insulin resistance, all of those other things sort of that drive cardiovascular disease risk. LPA, and, it's entirely possible that it's necessary but not sufficient, right? I mean, if you are otherwise a very low risk person from a cardiovascular disease risk, having an LPA elevated by itself may not be sufficient to drive the development of cardiovascular disease. I kind of think of it as almost like a risk multiplier in that way. So if you
Yeah.
have a really high LPA and you're insulin resistant and you got systemic inflammation and some of these other things, then certainly LPA is going to be a major consideration in terms of your risk long term. But I think it's, like you said, with apoE4, it's a window of opportunity for us to really focus on optimizing all those other elements that drive cardiovascular disease.
Totally. So, yeah, if you guys like, let's just kind of go through the algorithm of
Mhm.
how we'd look at this if you have an elevated LP(a),
Yep.
right? Because the people that are going to probably stick around past the first 5 minutes of this podcast probably might have some personal interest in this. Otherwise, they might be bored. I don't know. That's just my take on it. So, say you have an elevated LP(a), which we look at as like over 75 um, for in moles to
Do you
over
want to talk about the
liters.
cut points, just to give
We
people kind of
can. It depends. I
um,
mean, I think our guidelines, our standards are a little different than some.
yeah.
But yeah, let's talk about it, and then we'll talk about kind of what to do about it.
Yeah, so I think you alluded to the fact that there are two different units of measurement, which makes it really confusing, and they are not interchangeable. There is an equation that kind of will roughly convert one to the other, but even that, these are actually measuring slightly different things. So generally speaking, and again, this is pulled from some of the guidelines, a value of 50 or more milligrams per deciliter is considered to be a clinically significant increased risk. And then in nanomoles per liter, I think that equates to roughly 120 to 125 nanomoles per liter. So if you look at your lab report, numbers at or above those thresholds would infer an increased risk long term from cardiovascular disease.
What cutoff do you use?
I basically use something very similar to that. Now we have other breakpoints, like once you cross 90 milligrams per deciliter, that's considered to be a severe increase in risk. But whether it's 50, 60, 90, 100 or higher, or if we went to nanomoles per liter and said above 120 or 125, to me, whether you're moderately increased or severely increased probably doesn't matter a whole lot. We just know at that point that there is an increased risk of development of cardiovascular disease. So as you said, it's, to me, I look at it very similar to when I get a genetic report back that identifies somebody as being an apoE4 carrier or a homozygote.
Yeah. Yeah. Rad. So if you have an elevated Lp(a), the first thing I think you're going to want to look at is, and poke any holes in this,
Mhm.
because I'm curious how you handle this as
Yeah.
well, Damon, but just generally how we tend to handle it at Wild Health is first you want to really aggressively lower your apoB. And you also want to look at, like, is this diuretic risk or is there disease going on? Like, is this primary or secondary prevention of cardiovascular events at this point and
Mhm.
disease? So what is the age? And is this person appropriate for an angiogram at this point, right? Like, is this worth putting someone in a CT scan with a bunch of radiation and looking at the degree of plaques? So we're not big fans of calcium scores around here at Wild Health because there's a huge false negative rate. I mean, it's not really a false negative rate. It's accurate for what it's testing, which is
Mhm.
calcium index, but it's not going to pick up on soft or vulnerable plaques that are not yet calcified. And that's going to be problematic for primarily the younger population that hasn't had this brewing as long, right? So those are the first like one and two things that I look at. Granted, our population is a little different. We don't have a lot of smokers. We don't have a lot of people with like super low hanging fruit in terms of like some common cardiovascular risk factors in the world. But those are the first one and two things that I look at really aggressively if someone has a sky high lipoprotein A. Like, how are we truly risk stratifying them? Like, is this, something seriously going on right now? Like, if I have like a 70-year-old patient coming to me for the first time, and this is the first time they're getting their Lp(a) tested, and they're like, "Oh, I had a low calcium score 10 years ago. No big deal. I'm on a statin." I'm like, "We need to get an angiogram, right? Like, we need to see what's going on in this person to see what degree of plaque does intervention need to happen." You know, Oftentimes their apoB might be like 70, and we're gonna want it closer to like 50 or lower, and be more aggressive with that. So that's kind of the first area that I look at,
Mhm.
and that's gonna be really different. A lot of our patients are like 30 coming to us, and they might have these labs done for the first time. They might have normal cholesterol, like you mentioned, and just happen to have an elevated Lp(a). They don't know what that means. That's a common scenario as well. That person probably isn't a candidate for an angiogram just yet, but
Mhm.
you're probably gonna wanna put that on the agenda a little sooner than you would have otherwise in that person as
Yep.
their health trajectory goes forward, just so they're aware of screening when, like, the age becomes appropriate. Much like if you have a family history of colon cancer in your family, you're gonna get a colonoscopy a little earlier probably than you
Mhm.
would otherwise, depending on the age, and same with breast cancer and the mammogram. So I look at that very similarly. I don't know if that's how you handle these scenarios?
Yeah, that's great. I think we probably have a very similar approach from what it sounds like. What I do, I look at the kind of general lipid profile. Is this an atherogenic, pattern or not? I look at their methylation markers. Do they have a really elevated homocysteine level that is also a risk factor for clotting and cardiovascular disease? Are they insulin sensitive or resistant? Right, and if they are resistant, we really need to dial that in. So I kind of look at all the other potential risks that are modifiable, right? Things that we commonly address at Wild Health and make sure that we're doing all the things we need to do on that end. And then I think if all of those things are really optimized and it's just the Lp(a) as what appears to be the primary driver risk factor, then I think leveraging cardiac imaging in the right context, right, at the right time in life makes sense, right? I certainly wouldn't advocate a 25 or 30-year-old go get a clearly cardiac CTA or a heart flow study. But certainly, as they get to closer to 40 or beyond, if they have a strong family history of premature cardiovascular disease, maybe we're talking about doing that scan earlier in that person. But then I think utilizing these
Which you would
advanced,
consider that males before 55, females before 45?
yeah, I think generally, I mean, I think that's a,
And, like, if you have a family member that had a
yeah,
heart attack
right.
at those ages or
Yes.
an ischemic stroke, I suppose.
Yes. Yep. Absolutely. So
So
I think those are kind of general cutoffs that I use as well. So then I think you could potentially look at an AI augmented or even a standard cardiac CTA is got a fairly high level of sensitivity in that regard. And then you're looking at the anatomy of the coronary arteries, and if there is no measurable coronary artery disease, no plaque evidence, then that LPA by itself probably isn't, as we talked about earlier, it's a risk multiplier. I mean, it is atherogenic. It does confer risk of developing that. But at that point in time, if they've been living with this LPA level their entire life up to that point and they have no identifiable plaque, the urgency to try to do something else maybe is less versus the
Yeah.
person who does the scan and we find they have a fair amount of plaque burden, some of which may be modifiable. Then I think it does mean, to your point, that the apoB lowering, some other things maybe become even more important. I see a
Hmm.
lot of folks at Wild Health that are somewhat reluctant to get on lipid lowering therapy for totally understandable reasons. They're worried about side effects, or they've had personal encounters with the medications and haven't tolerated them well. And so a lot of folks are a little bit hesitant. So I think as we utilize these more advanced cardiac imaging studies going forward, it really does allow us to kind of further frame their personal risk, right?
Truly, and make an actually informed decision,
Yes.
right?
Yep. Absolutely.
Of are we treating theoretic risk or actual disease,
Yeah.
right?
Yeah.
So,
And this is certainly outside the scope of what we were talking about today, but a lot of
no,
folks
go
get
for it.
so a lot of folks get nervous about the radiation exposure related to some of these scans, which again is a totally reasonable thing to be worried about. The average person, we'll just use the United States, right? Because I don't know what the average radiation risk is other places, but in the US, on average, people are going to get somewhere between 3 and 6 millisieverts of radiation exposure just being alive, right? Going outside, going to work. Obviously, if you're in the medical imaging, it's going to be on the higher end. A low dose chest CT we use for lung cancer screening is about 1.5 millisieverts. So about half of what somebody would get just in a normal year. The cardiac CTAs are somewhere between 5
So
and
that 3 to 6 is per year?
per year. Yep. So you get in about a year. So you're going to get half that with a lung cancer screening CT, about 1.5. And then the cardiac CTAs right now are somewhere between 5 and 10 on average. So they're not far off from kind of what you get in terms of background radiation, just being alive on Earth over the course of 1 year. Now, if you take a bunch of airline flights, if you go hike up to, 10,000 feet plus of elevation, you're going to have gotten more radiation for sure, right? Because you're at higher altitudes. So the bottom line is these are not scans. The amount of radiation you get is very different than what you get from an abdominal CT or even kind of older chest CT protocols. The amount of radiation exposure has really decreased over time as the technologies advance. That's
That's
not to
awesome.
say that we need to be scanning 20-year-olds or 25-year-olds or even 30-year-olds, but it's not a massive amount of irradiation relative to what we kind of get just being alive on planet Earth.
Yeah. Well, I mean, but you're still getting that background radiation
You
addition to
you are.
this as
No, that's
well,
exactly right. So
right? So you're
it is
stacking
additive.
it.
Yep.
Yeah.
But I think there's a
But it
lot
all
of fear for people of getting any of these scans, even in folks sometimes I see in their 50s, 60s are really worried about that. And so
Mm.
once we frame it that way, where it's like, well, you're getting about a year's worth of just background radiation. It sounds like a lot, but it's very similar to what you get. If you go on an airplane, you're probably getting, especially if you're taking multiple trips, you're getting more than that anyway. So I think when you're talking about really honing in on the risk, and being able to tell somebody with confidence how much disease is present and what their likelihood to progress from there is, I think the potential benefits, again, in the right age context, outweigh the risk of that additive radiation exposure.
Oh, totally. I mean, especially if someone's of the age where like this is you're gonna have an action step at the end of this. Like,
Absolutely.
are you
Yes.
going on a med or are you not? Is this
Yep.
somebody that needs a cath or not? Like, this is
Yep.
these can be super, super insightful. I recently had a patient with a very low normal, like a low positive calcium score,
Sure.
very high risk genetically.
Yep.
And so seeing cardiology, was on a statin, and I'm like, I'm just not comfortable with
Yep.
this. Like, we need to know what else is going on. She had a
Mhm.
99% RCA,
Wow.
like, and it was all soft plaque. She was like a young, like, runner.
Yep.
Like, this is just there's things that they can just miss, and unfortunately, they tend to be the more tragic scenarios of these
Mhm.
younger, kind of fitter people because this is typically more genetically driven at that
Yep.
point.
Yep.
So, yeah, when it's gonna drive a decision, I mean, just like any test
Mhm.
in medicine, right? Like, are you gonna do anything different with the results, right? If it's
Right.
somebody that's, like, 25, probably not, right?
Yep.
You're gonna support their lifestyle unless they just happen to be, like, familial,
Mhm.
hyperlipidemia and, like, sky high lipids and like, there could be maybe some, like, nuance to that, but most of the time, you're not gonna do anything different in somebody definitely below 30.
Yep.
So what's the point of getting that test? And it just leads to really complicated conversations with no
Yep.
change in action. Not that we have a problem with the complicated conversations. It can just cause a lot of stress for people.
Yep.
So I totally agree with you. An interesting call out on the radiation point because it does come up quite often.
Yeah.
But I think the risk of heart disease is much higher than that
For sure. Yeah.
for
Yeah.
pretty
And
much everyone globally. So
yeah, absolutely. And I think just to double click on what you said, this is why we're not universally recommending everybody who shows up with abnormal lipid profiles or really high LP little A's get scanned, at a young age, right? I mean, I think it's once you cross, get closer to 40 or beyond, unless you have a real strong family history of premature coronary artery disease, we generally aren't doing these scans until you get to a point in life where we think the risk of long-term radiation exposure is lower and we're much more likely to have a decision to make on the back end of that scan from a treatment standpoint, as you pointed out.
yeah, because we're not going to have probably a different perspective. I mean, we might feel a little more strongly
Mhm.
about aggressive pharmacologic management if we have a positive CCTA on our
Yep.
hands, right?
Yep.
But we probably still would have had that recommendation. If someone has a really high apoB and a really high LP little a, we're going to recommend medication to
Mhm.
lower the apoB almost always. Um, you know, so it's, yeah, super interesting discussion. You brought up a number of the lifestyle factors and
Mhm.
other labs that we check, which is that kind of next tier that I think is honestly most applicable and most important
Mhm.
for the vast majority of the population who aren't like optimizing these risk factors. So you named out a number of them. So glycemic control or insulin sensitivity is a big one.
Mhm.
Blood pressure, I don't think you mentioned, is
Nope,
another
that's a
one
big
we
one.
really want to optimize. We want to look at your VO2 max, see what that's looking like. We want to make sure C-reactive protein or inflammatory levels are, as low as possible, definitely below 3 per the literature, but we really like it below 1. We want to look at your homocysteine. How are you methylating? Do you need more B vitamins to support that and get that number? Ideally, definitely below 10, again, per the literature, but ideally below 7. We
Mhm.
like it.
Yep.
So we want to really, really get these things dialed in from all facets.
Yep.
And then like exercise can't be underemphasized or overemphasized either. The evidence is like crystal clear on cardiovascular outcomes in exercise as well. So there's like a number of, we can dive into any of those, but there's a number of other things that like everybody should be
Yeah.
trying to
Yep.
optimize, in my opinion. But like you said, LP-little-a is a risk amplifier. So if you
Mhm.
know you have this risk factor, you want to really, really do these other things to optimize your cardiovascular health and make it as like resilient and robust as possible.
Yeah. Yeah, I think that's exactly right. I don't think that point can be overemphasized. It's as of now, without real clear approved treatment modalities for lowering LPA, we're really left with managing risk around that particular number. And as we've said this a few times, that I really think that the ApoE4 analogy is perfect here. I mean, we don't have a therapy to fix that allelic problem, right? That genetic issue. So we just have to, it means that all the other things that we can modify need to be optimized to the extent they can be. And I think the overview you
Yeah.
just gave is exactly right.
Nice. So let's talk a little bit about drugs. We
Mhm.
don't need to dive super deep into this because this could be a whole podcast.
Yeah.
But let's give an overview of kind of what people have used that maybe
Mhm.
didn't work as well
Yep.
historically, what's been tried, what we do. We talked a little bit about statins and PCSK9 inhibitors already, and then maybe what's coming down the pipeline.
Yeah, great. So as we've said a few times, there isn't anything that actually is validated and approved for treatment of the elevated LPA yet. I mean, the PCSK9 inhibitors we said will decrease that number often by 20 to 30%. Statins have a more variable effect. Sometimes they will lower the LPA, at other times they'll increase it. There are several drugs being tested in various phases of clinical trials now, and these really kind of break into two broad categories. Either they inhibit production at the gene level of LPA, or they prevent the LPA, the tail molecule, being attached to the LPA particle. Um, the gene therapies, one of them is called an antisense, and then the other is these are called small interfering RNA molecules, and so you'll start seeing that those topics are popping up now in the literature as these
Yeah,
clinical
people might
trials
see it
progress.
as ASOs.
Yes, exactly. That's another one. And so one of those therapies, potentially the clinical trial wraps up this year, or early next year, and then maybe FDA approved within the next 12 to 24 months. Those, certainly the therapies that work at the gene level, are decreasing LPA by as much as 99% in some cases. So profound lowering of LPA with these treatments. The other one is an oral molecule that I mentioned that prevents the apo tail being attached to LPA. It's an oral tablet or capsule that lowers LPA by about 80%, just based on the preliminary data that's been released so far. And so we'll have several different medications potentially FDA approved in the coming years that will directly lower Lp(a). They seem to be well tolerated. I haven't seen a lot of side effects described yet in the available trials, but these are not yet FDA approved.
This is
Obviously, still
new.
more,
Yeah.
yes, definitely more study to be done, more validation, more long-term outcome data needed before we can speak to that with certainty. But I think they're certainly promising for people who have a markedly elevated LPA and potentially have a lot of other risks, right? You think about the person who has a really high LPA that has apoB issues, that maybe has some insulin resistance problems that they're struggling with, or maybe they have an increased LPA and they're an apo E4,
Mhm.
when you start combining a bunch of these risk pathways, then I think the urgency to treat that number potentially changes.
Yeah, totally. And the mainstay for now is still get that apoB as low as possible. And if you're super high risk or know you have soft plaque or something else is going on, like an adjunctive or patha is not a bad idea. I have the question probably almost daily, definitely weekly by patients because there is some hesitancy around statins for a
Mhm.
number of reasons.
Yeah.
What about just Repatha?
Mhm.
What about just a PCSK9 inhibitor, the absence of the statin as a primary treatment, which is typically not the recommendation? I'm just curious your thoughts on it. Not to put you on the spot, but I know this is an area where you jam out. So
Yeah,
just curious
yeah.
what your thoughts are.
Yeah, this comes up often. For me, it's usually in folks who have had either personal issues with statin tolerance, or they have close family members who really have struggled with some of the myopathic symptoms in particular. And we have the same conversation, right? It's not the preferred treatment to do just the PCSK9 inhibitor by itself, unless you really can't tolerate that. But I think we have had people who have wanted to preferentially opt for that therapy, um, that monotherapy up front. And then it's that individual conversation about whether we could modify the statin, the type of the statin, or whether we could modify the dose or those sorts of things. And then I think it just gets into it's an informed risk discussion, like everything else we do in healthcare these days. I certainly have had folks who have been able to get on drugs like Repatha as a monotherapy and have tolerated them well, and have had really impressive, decreases in apoB specifically. So I think it does work that way, even if that's not necessarily the preferred approach up front.
And there is just to be clear, there's a subset of people who genetically do not respond to these
Absolutely.
PCSK9 inhibitors
Absolutely.
well. So just
Yep.
FYI,
Yep.
for anyone listening, a lot of these people that ask me this are, yes, the first category you mentioned, people that have had bad experiences or know someone with a bad experience with the statin. Then there's a big percentage of people that are younger and just have
Mhm.
read a lot,
Yep.
have heard a lot of the talks about statins.
Yeah.
Statins have become a little bit controversial,
Yep.
right? And a lot of the data that suggests statins, because there's a lot of data on statins and we don't have a lot of data on some of these other things, right? So, and there's also really, really good outcomes in a lot of these things, right?
Yeah.
So it's a super nuanced conversation, but for these like younger, not always younger, but often younger populations of
Mhm.
people that may not have a lot of disease yet and just have some hesitancy around the
Yep.
statin conversation. This is just something that can come up. And I do the same thing. I have that conversation and then I say, we just don't know,
Yep.
right? Like we don't have the same level of data. So it's not the recommendation right now. But like if this is something you feel strongly about, it's probably way better than doing nothing.
Okay.
And let's check the labs in, 8 to 12 weeks and see where we get, right? Like see what happens.
Yeah, I've had lots of folks who have just opted for, close surveillance and lab monitoring, and then we figure out what is the right time to get some of these cardiac imaging studies. Does it make sense at your age? Do we have a time frame where it might make more sense? And then it's just looking at all those other elements of risk that we keep talking about, right? I mean, if they're fully optimizing every other way and there's no strong family history and they're very, hesitant, then certainly I'm happy to follow along, measuring labs and doing all the things that we can do until we feel like the time is right, maybe for some of these
Yeah.
cardiac imaging studies. Yeah.
Totally, totally. Um, I probably use around 75 more often for my cutoff of nanomoles per liter in patients. I don't know if that's where you lie, but if anyone's curious in getting this tested, that's where I
Mhm.
kind of start like paying more attention to the cardiovascular risk. You're gonna see a lot of people that are like super low, like less than 10
Mhm.
on their Lp(a), and they obviously aren't genetically, predisposed to raising this number.
Yep.
And then there's a small subset of people you're gonna see like over 200 or over 250. Like it's going to be super sky high. And those really catch our attention, obviously. So
Yeah.
just to kind of break
They're all on
down
my
the
panel right now. All of those patients are on my panel.
really,
Yeah.
we sent them
I
all to you on purpose.
Yeah,
We
that's
all
right.
had a
I
meeting, Damon, and
Right.
we were like, Damon really likes cardiovascular optimization. So
Yeah.
let's,
Yeah. I have
I'm
several
kidding. I'm
folks who have
obviously kidding. We did not do that. So for anyone listening,
Yeah, lots of folks
um,
with 2 to 300s, milligram per deciliter, really, like, profound
yeah,
elevations, and then with that
yeah.
unit of measurement, remember 90 and above is considered severe risk, so,
Hmm.
and it's a spectrum like everything else. We like cut points in medicine because we have to describe, things at some point in time and speak the same language, but this is a continuous spectrum, so certainly if 90 is bad, 150, 200 is also bad, right, on that spectrum of severity, so yeah.
Yeah. So I can think of a couple people off the top of my head that I've recently seen, and
Mhm.
just to go through a couple of cases for people because I think they really hit home. And a lot of people come to us and like, I know I have this number, I don't know what to do.
Great.
I have one patient and his cholesterol is very well controlled. His apoB is very low. I think it's in the 50s or 60s. And he's lifestyle's like super optimized,
Yep.
but LP little a, I think is like 90s, maybe low 100s.
Mhm.
So this is a patient, I think, in his early 30s. So we just had the conversation and low family history, like no really other risk factors, just like
Mhm.
isolated Lp(a) elevation, essentially in this person. So we had that conversation of like, probably we'll do an angiogram around 45 and we'll keep
Yeah.
an eye, continue to keep an eye on your lipids, make sure nothing changes, keep an eye on those other risk factors and really put your efforts into those like cardiovascular optimizing like lifestyle, levers, in terms of what's going to get that person the highest ROI on their longevity. I
Sure.
have another patient I can think of that in their mid 30s came to us, has very strong family history of early cardiac disease and has LP Lilly over 200 and could be vegan and has very high apoB and LDL, just produces the heck out of cholesterol and lipoproteins. That person we put on a statin at a young age and we'll get an angiogram probably around 40 in that
Mhm.
person. So just a couple of examples of, and we're able to optimize those numbers on a statin, but
Mhm.
just a couple of examples of like handling things differently
Yep.
in different type of cases, but like common scenarios that we see
Yeah.
that like people are just walking around living healthy lifestyles would have
Mhm.
no idea. Like these people
Yep.
come across very similarly
Yep.
in terms of their day to day.
Yeah, I agree. I mean, this, if you kind of read about LPA, folks are calling this the silent killer, right? Because it isn't going to cause, I mean, it's a little bit like apoB in that regard. You're not going to know that you've got these really, in some cases, astronomically elevated levels. This requires lab screening to really identify that risk. And so that's the challenge, is that a lot of these things that we know are both predictive and atherogenic are actually causative, are going to do a lot, potentially, right? Could do a lot of long-term injury, and you not know it really until you have an event, or until somebody does the right sort of screening or evaluation to identify that. That's the challenge. But I like the
Yeah.
fact that you said, and I think this is true for everyone, like we have to personalize all of this, right? I mean, LPA is still a number, right? It is not a guarantee. It is a risk. It is maybe a risk multiplier. So we have to personalize, how urgent it is to try to do something about it, I think, when we can, and how we treat the modifiable risk factors, and when do we get imaging. All that stuff really has to be indexed to that person. Everything is context specific, including LPA.
Yeah. Totally. Okay, let's talk about quickly the inflammatory aspect of things. This is something talked about a little less commonly, I think,
Yep.
and frequently. I'm not sure. I get personally curious about this because I work a lot with autoimmunity. I don't think there's been any evidence, and correct me if I'm wrong, of like actionability here in terms of like inflammation lowering meds, reducing LP(a), which is where my mind goes when I
Yeah.
think of these things.
Yeah.
But just like fill us in on this because this is something
Yeah.
I think you know a lot about. Because especially you see people in like acutely inflammatory scenarios in the ICU, right? So give me a little Give us a little bit of info here.
Yeah, I definitely find this to be fascinating. So we said about 90% of LPA is genetically derived, right? So that means about 10% comes from other things. And so inflammation, whether acute or chronic, is another mechanism by which LPA can become elevated. And the reason for this, the LPA promoter has an interleukin 6, so interleukin 6 being an inflammatory molecule. It has a IL-6 responsive portion to it. So when you see these, when your body is going through some inflammatory insult and your body is upregulating a lot of these interleukin and inflammatory sort of mediators, that also can stimulate production of LPA. So
Mm.
as inflammation goes up, potentially LPA also goes up. And I think what is interesting is I get a couple of questions about that. As you said, if we treat the inflammation, does LPA get better? And the other question is, what is the magnitude of LPA elevation with some of these things?
Well, one other question that literally just dawned on me. Do
Yeah.
you know, has it been teased out? Is this just happening in the people with the LPA gene active, or is this happening is everybody more likely to increase LP production in that scenario?
Yeah, good question. I don't think this is, I don't think that's been fully worked out yet. I mean, certainly not everyone seems to respond. So my guess is there's going to be some genetic variation there where some people tend to be, inflammation responders, I guess, for lack of a better phrase, and more likely to have LPA numbers that rise rapidly in the setting of inflammation. And I think, you know, and that probably explains the heterogeneity in the literature, right? If you look at different inflammatory states, like for example, and with autoimmunity, when you have flares of things like rheumatoid arthritis, you definitely can see 10 to 30% increases in LPA over baseline. With chronic inflammation from autoimmune diseases, typically you see less of an elevation, maybe 10 to 15% over baseline. But in the setting of something like an acute myocardial infarction, a heart attack, I mean, there's certainly cases where LPA might double or triple, right? There's an initial drop, and then you might see a 2 to 3-fold increase over baseline. If somebody's living at 90, you could easily see them jump up to nearly 300 in the acute setting. And
So I never checked this as a hospitalist, and I'm like, this would have been so fascinating to
yeah,
understand this more.
yeah,
Even in
probably.
people in, like, a cytokine storm or, like, different scenario I'm just thinking through different scenarios when I worked in the hospital, like, it would've been so fascinating to understand this a little bit more. I mean, you certainly see a higher incidence of cardiovascular events in these scenarios.
Yeah, so I think obviously the guidelines haven't endorsed doing that, and we haven't really done that broadly, maybe in part because we really haven't had a lot of LPA specific treatments up to this point in time, but
Like,
it
what do
would.
you do about it anyway
Yeah,
other
I
than
think it would certainly give us a better understanding of how prevalent this is in the population at large, but I think maybe more pertinent is understanding that inflammation can impact this in some cases and maybe even profoundly in certain individuals. So I think if you're getting an LPA, you're drawing it in the context of somebody being in a highly inflamed state, right? If you have a CRP value that's quite elevated, or they're struggling with an autoimmune flare, or certainly if they just got out of the hospital from or treatment for a heart attack, and that number is really elevated, it probably warrants repeating it maybe a month or two later, or certainly once the inflammatory situation under better control, because you can see these sort of artificial rises, and it might change your sort of, your risk analysis.
Well, so we've talked about what to do in terms of long-term risk analysis
Mhm.
for like atherosclerosis and
Yep.
cardiovascular events in a long-term setting in someone's lifespan, right? But
Yep.
like in the acute setting like this, like how would it change your like say someone did have that
Yep.
huge uptick, like would you do anything differently?
Well, so the way we always evaluate things, we typically are wanting to know, at least to get some surrogates for systemic inflammation, right? So we're often checking high sensitivity CRPs in conjunction with these other labs. So I think we at Wild Health are often going to have some sense of whether there is another process maybe going on at the same time that needs further investigation. If I didn't have some of that information, I would certainly want to know, do they have evidence of an increase in systemic inflammation? And then really a lot of it's going to be historical. Have they had a recent acute event? Do they have some underlying autoimmunity that needs to be investigated? So for me, it doesn't change necessarily treatment in the acute setting per se, but it might push me into investigating some of these other pathways to try to figure out whether there's something acute superimposed on this, maybe
Mhm.
what is otherwise a chronic LPA elevation.
Totally, kinda looking retrospectively at, like, what else could be going on in the
Yeah.
setting of this risk. That makes total sense, and it makes me wanna be I'm already really mindful of the cardiovascular risk,
Yeah.
if it like, in the context of autoimmunity,
Yeah.
systemic autoimmunity, like, that's well known in the literature, and
Yeah.
that's something to that's, like that's another risk factor that you wanna be really mindful of when to screen and how to treat and all these things. Um, but I'm just curious, like, with how Lp works, would it make sense for some of these people to, like, transiently be on aspirin in this setting? Or, like, you know what I mean?
Yeah.
Like, I'm just kind of like, this is how my brain works. I'm just thinking of applications, like acute applications in these scenarios when someone is in a highly inflamed state. Do you want to be ultra protective of their cardiovascular health in that, brief period? Uh, I don't know. I'm not
Yeah. No,
pinning
that's a
you down to say what your protocol should
yeah.
be. I'm just kind of like thinking out loud.
I mean, it's a great question. I think it's a clear gap in the literature, right? Because I still think the connection with inflammation, it's known, and right, there are some really interesting studies that have been published the last few years that have really sort of elucidated the mechanisms, but I don't think we have any idea of how we should be responding in the acute setting when we see this relationship between inflammation and elevated LPA. Now, we do know this was not a primary endpoint, but some of the studies where we have used some of these anti-inflammatory immunosuppressive therapies have led to a reduction in LPA. Usually it's not an impressive amount. We're not talking about 80 or 90% reduction like some of the LPA drugs that are coming down the pipeline, but in some cases, maybe 20 or 30% decrease in LPA. And I think that speaks to that
Yeah.
that relationship, from a mechanism standpoint. But
Hmm.
it would be difficult to advocate for treating somebody with pretty potent immunosuppressive therapy just because of that, right? You would want to be treating them with that if it was indicated for their underlying
Yeah.
disease, not because of
Yeah,
their
how does
disease.
it fit in the rest of the
Right.
context of that human being?
Yep.
For sure. I also am so curious, I don't know if there is any data on this, I did 0 research on this particular question I'm about to ask before I say it live on the podcast, which is great,
Yep.
but, it also makes me think of the earlier strains of COVID
Mhm.
when there was this thrombotic scenario. Clearly, there's these cytokine storms. Do you know if there was any data, linking, like, if anyone was testing Lp in these scenarios? It just seems like they would have been quite bumped.
Yeah, so I'm not aware of any. It doesn't mean it wasn't done, but I'm not aware of those studies. LPA just I think we let off with this early on, but it's still not even being checked broadly as a screening mechanism at the primary care level. So I think many people, physician colleagues of mine, still don't fundamentally understand what LPA is and
Mhm.
how it fits into, a kind of lipid screening in general. So I doubt those studies were done, but I wouldn't be surprised had they been done that LPA would have been substantially elevated. I've certainly seen really high LPA numbers in hospitalized patients who have had, acute MIs, who have had other issues, but I'm not even sure why those got checked, in that setting. Usually it's
Yeah,
just a
totally.
standard lipid profile. It's not usually the LPA that goes along with that, but I think those were kind of incidental things. Yeah, I'm not aware of the COVID link, but it would be a fascinating thing in retrospect to look
I
at.
always got in trouble for, like, unnecessarily checking labs as a hospitalist, right? Like, "Why did you check this?" I'm like,
Oh,
"Well,
yeah, yeah.
doesn't
People
make
look at
sense."
me. Yeah, they do this sometimes when I order labs like that in hospitalized patients sometimes, and I was it
Uh-huh.
might so yeah, people sometimes look at me a little strange
Yeah.
when I'm
Or,
ordering.
like, I would call the cafeteria and be like, "This is not the right diet for
Right.
this diabetic patient that just had an MI." And they're like, "This is a diabetic diet." I'm like, "Let me just come down. Let me just
Yeah.
show you." Like, I didn't yeah, it didn't fit in there.
Yeah. I
Um,
certainly understand
cool.
that.
Well, awesome. This has been super enlightening. Let's give some like takeaway points if there's anything you'd want people to know. So this might be super new, and if we have like 2 people still listening, that's awesome. Um, so for people who this is new information to, maybe they are a primary care physician or an
Yep.
ER physician or whatever it is, right? And this is something that like we didn't learn a lot about medical school, right?
Yep.
Or residency. I didn't. So what do you think are kind of the biggest take home points?
Yeah, good. So I think everyone should get this checked at least once, right? I think that's pretty clear. Everyone should get this at some point in time. And then I think the other important piece is to understand this is a potential risk factor, a substantial one, both risk factor and predictive risk, but also potentially causative in relation to cardiovascular disease. And so it's important to know where somebody stands, in terms of their LPA. And if it is substantially elevated, then it just reinforces and maybe creates more urgency to optimize all the other cardiovascular disease risk factors we talked about for now. Now, there are therapies coming down the pipeline, and it might be that somebody warrants treatment for their elevated LPA. I think that will very much be an individualized or personalized decision for sure. But I think those are probably the most important points of this. Know what LPA is, make sure it gets checked at least once. If it's elevated, it's not a guarantee that you're eventually going to have a heart attack or something else, but it does mean that we need to take, the optimization around those risk factors really seriously and maybe more urgently than we would otherwise.
Yeah, badass. I think that's such a good summary. I like to tell people like we all have areas of genetic vulnerability and
Absolutely.
areas of superpowers, right?
Yep.
And that's just one thing that could get
Mhm.
uncovered. Same with apoE. These are things that can feel super scary if you get these tested and they're positive. And I get it. I get not wanting to know those things, but it's gosh, it's so empowering when you can essentially studies have shown, at least with apoE, you can largely reduce your risk to baseline when you optimize other lifestyle factors and other risk factors associated that are well within your control with your lifestyle, supplementation, et cetera. So super powerful stuff. It just helps us treat you the right way when we have the data. Like we can manage what we're measuring, right?
Yeah,
So
exactly right.
super powerful. Thank you so much. I've learned today. Hopefully listeners have learned. And it was great talking with you.
Yeah. Thanks for having me. I really appreciate it.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.